picking up perspective, I can't tell you that because you wouldn't be picking up from me generally speaking.
Right.
From the delivery perspective, what I need from you is a really good maternal history. Of course, any paperwork that they provided you, of course. And y'all tell me why I want to know the history. I want to know things like gestation. Why does that matter?
Because you want to know how far along they are.
How far along? Because does it make a difference if she's 30 weeks versus 37 weeks?
Well,
It
yeah.
does.
Yeah.
Right? Okay. So gestation. What about medical history? Why do I care about that?
Because if she's got diabetes or hypertension or
blood pressure, things like that.
Eclampsia.
Absolutely. Seizure disorders, eclampsia, things like that. So gestation, medical history, OB history. Why do I care about that?
Because if she's had
Multiple births.
Prior complications.
Yeah.
Prior complications. Specifically what? Couple things come to mind.
She's had to have a C-section before?
Right, C-section, because that makes a difference, right? Because she's got a scar on her uterus. So if this is her 5th baby, how did she deliver the other ones? If she had 4 C-sections, then that puts a different thought in my mind, right? Okay, so medical history, gestation, obstetrical history. So how she delivered her other babies. Also for you guys, if you're transporting her from, let's say, KMC to Forsyth, it's baby number 7. Does that matter?
Yeah.
How come?
They might fall out.
Exactly.
Might walk out on its own.
Exactly. The more you have, the faster they come. So in your mind, you're going to be thinking a couple steps ahead, right?
Yeah.
Okay. So obstetrical history, that's gestation, how she's delivered her babies before, how many babies she's had, what else?
Prenatal care.
Prenatal care, yep. And you're asking that for me as the receiving L&D nurse, because I want to know that. Has she been to the doctor? No. Because then in my mind, I start thinking, I don't know anything about this baby or this patient. So I need to start thinking, preparing for the worst, so to speak. Now, if she's had prenatal care, let's say she's had 11 visits, then at least she's got some data I can pull from when she gets to the hospital, and I know that her baby, she's had an ultrasound, her baby's normally formed. I could pull her blood pressures from a couple of visits ago, those sorts of things. But if she's not had any prenatal care, I don't know anything.
Okay, so say she didn't have any prenatal care. What are some things we can do en route that y'all might need when we get there? Because that happens a lot.
To try to get any history that you possibly can. Have you been to the doctor anywhere? Have you had any tests? When was your last period? Any information that you could try to deduce a due date. Even if it's just a very general, she might be 27 to 34 weeks, but here you go, sort of thing. So how many babies has she had her babies? How many weeks she is? Obstetrical history, C-section, vaginal delivery. Number of babies inside, right? 1 versus 2 or 3 or 8. Gotta know that. What else? One more thing I'm thinking about.
Active labor?
Bleeding.
Bleeding.
And or is she ruptured? About her, is her bag of water broken? Okay. So bleeding, there are 2 different kinds of bleeding when you're pregnant. Well, 3 different kinds, technically, I guess. The first kind is painless, bright red bleeding. And that's usually from a patient who has a previa. Okay. Number 1 rule for those patients, keep your hands out. Okay. Nothing goes inside. The other kind of bleeding is bleeding from an abruption. So, do y'all remember what an abruption is? Where the placenta is detaching early. Okay. So, previa, painless, bright red bleeding. An abruption, their bellies are hard. Y'all remember that, like tabletop hard. So, that's one of the things that you're looking for. That bleeding is not bright red, generally speaking. It's a little darker. Okay? So there's previa, there's abruption, and then there's one more kind of bleeding. Not really bleeding, though. bloody show. Have y'all heard that term before?
Yeah.
What is it?
Is that like the
Mucus plug.
You were all correct. So bloody show is a normal part of labor, okay? And it generally is mucusy, dark blood, snot looking stuff. I know, so attractive. Okay, that's what it looks like. That's the women have mucus when they're pregnant because of the hormone changes and everything. So that kind of brown bloody show is coming from the cervix. That's dilating. And so when the cervix dilates, those little vessels in it pop. And so that's where you get that mixture of mucus and blood. Generally, that's not bright red. It's dark, old-looking stuff. So a good rule of thumb on a pregnant woman is if she's bleeding and it looks like it's coming out fresh from the tap, that's not good. Okay? That's just a nice general rule of thumb. Even postpartum bleeding, so that technically could be your fourth kind of bleeding. So there's previa, abruption, bloody show, and postpartum. Even your postpartum bleeding doesn't look like it's coming fresh from the tap. That lochia looks different as well. But a general rule is if it's fresh coming out of her, you got to investigate that. Okay, do something about that. Does that make sense? Okay. So I want to know about bleeding. So we already talked about that. And then if she's broken her water. Now, what specifically do I care about?
Cord prolapse.
Cord prolapse, maybe. Yep. I heard time. Did somebody say time? Okay. So a good way to remember what we need to know about amniotic fluid or about rupture of membranes, use the word TACO. T-A-C-O. Okay? T stands for time. A for amount. C for color. And O for odor. So why do I care about those four things?
There's an odor, there might be infection.
Yes. Perfect. So odor might be infection. Okay? What about time?
Would that
They're kind of linked. The T and the O are kind of linked because if she ruptured 3 days ago, she might be infected. So those are linked. And the amount, is it a tiny little bit or is it like copious amounts of fluid? It's just because I like to know that. And then what about color?
they stored right?
Meconium.
Meconium,
Exactly.
yeah.
That's exactly right. Because it's supposed to be clear. So if it's not clear, if it's that greenish kind of color, then I need to know that. If you looking at her bottom in the back of the truck, you're almost here, and you look down and you see this greenish colored fluid coming out, I need to know that because if she's about to deliver, then I need to call NICU and have them ready for delivery wherever y'all are bringing her to. Okay, that just helps us be a step ahead of the game. So obstetrical history, that's pretty much about all you need to know. Now what if she delivered on you? What do I want to know? You're bringing her and a baby to me. So I'm going to ease your mind about having a baby. Okay? Really and truly, having a baby is the easiest part of an obstetrical nurse's day. That's the goal. And they generally come out. Okay? Your number one rule, my number one rule, a physician's number one rule, if you're delivering your baby, this is the number one rule. Don't drop it. As long as you don't drop it, you're good. Okay? That's the number one rule. The golden rule. Okay? Number two rule is cold babies or sick babies. So keep them warm. What do y'all have in the back of your trucks that will help you do that?
Mom.
We have one of those blankets.
You said mom. Did you say mom? You said mom. So mom is your best heater. Okay? She is. She's the best heater. And we instinctually, as women, after we have babies, actually dads I think probably do it too when they hold their babies, we will raise our temperatures by about a degree to warm our babies. It's instinctual. Don't have to work at it. So you deliver, you got the warm blankets, you got the little hat, take her gown off, take her clothes off, put that baby belly to belly. Okay? Nothing in between them. Baby skin to mom skin. Cover baby up. Okay? wipe the hat off, wipe the hair off, wipe the head off, and then put that warm hat on. Okay? That will keep your baby warm, because cold babies are sick babies. They don't like to be cold. What's the largest surface area of your baby? Exactly, it's the head. And where do you think it's going to lose most of its heat from? The head. And what happens if it, let's say it were 18 degrees outside and my hair was wet and I walked outside? How's that going to affect me? I'm going to get colder faster, right? But if you dried my hair and put a hat on me, I'm not going to get as cold as quickly, right? Same concept with babies. So if you dry the head off, get that largest surface area dry, some babies are born with lots of hair, and then put that hat on them, mom belly to belly, you're going to keep them warm. So number 1 rule, don't drop it. Number 2 rule, cold babies are sick babies, so keep them warm. If you can remember those things, you will be successful. If you're precipitously delivering a baby where you are, it's going to come out. Okay? It's just going to come right out. You just have to make sure it doesn't hit the floor. Okay?
Now, should we clamp the umbilical cord, or just wait till we get to the hospital?
It depends on how far out you are, I would imagine. You could leave it, you could clamp it. If you clamp it, what you need to make sure is that your clamps are clamped. So if y'all got hemostats or Kellys, how many clicks do you hear? 3. So I want to hear that 3 clicks, 3 clicks. Okay? And then you cut right in the middle. With all that transporting back and forth between stretchers and beds and everything, if those clamps aren't clamped well enough, one of them could come loose. And, you know, if it's on baby's side, there's not much blood volume from your baby. It's not going to take very long for him to bleed too much. And from your mom, if that placenta is still attached to the uterus, there's all those fresh, wonderful arteries that are going to bleed out through that cord if it's not clamped. So hearing those 3 clicks is very important, okay? Especially if you're going to do from transferring from bed to bed and side to side and repositioning and things like that, okay? Because some cords are long, so it could get caught up underneath mom.
Where's the placement again for the cord? Where do you?
So generally for baby, I would leave enough that if baby had to go to the NICU, they have enough cord to work with, so they can put lines in, okay? So I would say a finger length between baby's umbilicus and your first clamp is just it's a good conservative length, okay? I wouldn't go right up close. That doesn't give the NICU much to work with, if that makes sense. From the maternal side, it doesn't matter.
Okay.
Just as long as it's clamped tightly. So you clamp, and cut right in the middle. Okay? But make sure those clamps are nicely clamped. If you have an umbilical cord clamp, I don't know if y'all have those in your kids. Same rules apply. You want to hear that click. That's just that single click. Depending on how fat the cord is, it might be a little bit tougher to clamp it down well. If it's a skinnier cord, they generally are easier. But if it's a big fat cord, it might require a little bit more effort, and that's okay. You want the cords to be big and juicy. So if you use the umbilical clamp, same rules apply. Leave enough between baby and your clamp that NICU has something to work with. And if we need to trim it down, baby's great. We need to trim it down. We can do that in L&D. That's not a problem. I would rather you leave too much than not enough. Okay. So history, medical history, obstetrical history, if she delivers, what time, if you remember to look at that. And then what do we do as a kind of an assessment for babies? Do y'all remember right after they're delivered? At GARS. And I know you have that in your, yep, you have a little badge, buddy. So do you have questions about at GARS? Crying pink babies are super fantastic. That's what you want. But do they come out pink from head to toe?
No.
What's not pink? Hands and feet. Right. What should be pink?
Torso, yeah.
Perfect. Torso, mucous membranes. Just like you would on an adult. You know an adult is perfusing themselves by looking at their mucous membranes, right? Babies are the same way. They should be pink in their mouth. Their core, their trunk should be pink. Their hands and feet, and maybe their extremities might not be as pink, but their core should be pink along with their mucous membranes. y'all know more than you think you do. Why am I here? Super fantastic. So baby's delivered at GARS. What else? I need to know time. We got this placenta thing hanging out. What do you do with that? Leave it. Make sure it's clamped. I look down every now and then, make sure your clamp's still good. And check her bleeding. You just want to make sure that her bleeding.
Massage.
Well,
Wait until we get there.
generally the placenta probably acts as a cork. But if you notice that she is bleeding more than you're comfortable with, then you can do your bundle massage. What should it feel like?
Should be firm.
Should be firm. I imagine like a grapefruit or a soft ball hanging out right there in the uterus. That's what it should feel like. It should be firm. Okay. But as long as her bleeding is okay, you don't necessarily need to do anything with the placenta. Okay, you can just leave it. Because you're probably going to be where you're within some sort of facility that you could take her there if you needed to. So I wouldn't worry about the placenta. Placenta, baby. What's the number 1 rule?
Don't drop.
What's the number 2 rule?
Keep them warm.
Okay, cold babies or sick babies, keep them warm. Alright? Questions. So let's say baby's born, placenta comes out right after it. So it's not in there anymore. You're worried about bleeding, right? What do you do for that? We're talking about massage. Okay, so you're massaging the fundus.
So it's firm.
So it's firm, so it feels like a grapefruit sitting right there, or a softball, nice and firm. But what's that correct procedure for those bundle massages? Do you remember that?
Top or push it down with your fist and.
Okay, there's another step to that. So there's here, and then there's this other hand. Y'all remember this? Putting the other hand here. Did y'all ever learn that? Okay. So I am left-handed. So I'm massaging fundus with my right hand. Okay. I take my left hand, and if you put it right above the pubis symphysis, so right here, okay, and you want to, kind of like a C, I guess, and you want to kind of put a little bit of pressure right there. Because what you're trying to keep from happening is you're doing all that nice massage, and then the uterus does what? Falls right out. That's not what you want. Okay? You want to keep it in. You don't want it to fall out. Right? So this right here, this pubis symphysis, so it's a 2-step process. You need both your hands. Okay? One hand here, and the other hand, some people will karate chop. They'll do it like that, you know, and some people will use their fist. I use my fist. There's no right way. But where do you start? I'm just pushing randomly on my belly, but where should I be pushing?
Center.
Okay? So you want to push at the fundus. And the fundus is the top of the uterus. So if you can imagine the uterus is sitting in here like this.
And it'll be about your belly button.
About your belly button is a great place to start. You're exactly right. So start at the umbilicus, so right there at the belly button. And what you're feeling for is that nice hard grapefruit or softball sitting right there. Okay? And you'll feel it, and it might actually respond to your massage. It might firm up even a little bit more. What if it's not firm? Boggy. It's boggy and bleeding. It's a good word, boggy and bleeding. What do? You keep massaging, right. And then you're lifting up the covers and you're looking at her bleeding, okay? When I check for postpartum bleeding, I change my pads every single time I check it. That way I know I have a fresh start. So if you're doing it every 15 minutes or 30 minutes or whatever, if you change your pads every time, you know that between here and here is what she bled. Does that make sense? Because if she's bleeding off the side of those pads, that's probably too much, right? Mm-hmm. Right, okay. So that's just a good prudent practice, is every time you're checking, change your pads. So that way you can tell between checks.
And for us, it'll be every 15 when you do your vitals and everything.
Yep.
At least.
And even in L&D, that first hour, we check it every 15 minutes. So that is totally appropriate.
So what would be a little bit of blood to me might be a lot to someone else. So can you kind of give us an idea of what?
So what kind of pads do you have? What would you have under her?
Whatever we got from the other hospital.
Whatever you got from the other hospital.
Shots probably
So the blue chucks.
Yeah, that's what we probably have getting, yeah.
So those things are super fantastically absorbent. They hold a lot, like several hundred mLs. They should not be entirely saturated. Okay, that's too much. So if you're saturating a blue pad every 15 minutes, it's too much. Okay. I would say, and we historically, as nurses, physicians do it as well, probably underestimate blood loss by about 50%. So what you think would be 200 mLs is probably more than that. That's what the literature says. Some of us are a little bit more accurate than others. Do you have like peri pads or pads or anything like that? Like
We can add a little liquid to the truck.
you don't have to. Those generally hold about 50 or 75. I can't remember the number.
It'd probably be easier changing those pads than it would the blue chucks on a
Right.
stretcher.
Yeah.
Right.
We can throw a bag of those on each truck, it's not a major issue.
Yeah. So that might be easier for your blood loss because they hold like 50 or 75. So that's a little bit easier to add up and keep up with.
You're talking about the little ones.
Yeah, the little like pads, like maxi pads. Yeah. Those might be a little bit easier. You know, if you're going through several ones of those every 15 minutes, like completely saturated, you know, that's at least, 150, 200, you know, if you say you're doing 2 of them. Because I think they hold about 50, but I can get back to you on that because we've actually tested them. We poured fake blood on there and tested how much they hold. And if y'all get to come over to the hospital and play, we will let you practice your blood estimation. So you'd be able to see how accurate you are. And blood looks very different in a cylinder versus in a big round splotch underneath somebody. But if you're using those maxi pads, then I would say they hold about 50. It's just a good conservative estimate. Okay? So every 15 minutes, so you would change those pads. Now if there's not much on there, that's okay, but there should be something. So if you're checking her belly every 15 minutes and nothing is coming out, maybe you're not doing it hard enough. And let's not forget, this patient's awake, and you're like, let's southernize it, you are mashing on her belly. What's she gonna do?
Scream.
And probably grab at you. So just be sure that you're educating her as to why you're doing it. And I usually have my patients grab their side rails. Just, can you grab the side rails? This is not going to feel fun. I am so sorry. We just want to make sure that you're not bleeding too much after your delivery. Okay? You would only do that after delivery though. Okay? So fundal pressure, the top of the uterus. Now if it's boggy and you've massaged it and it firms up, stop. Because the uterus is muscle. What happens to your muscles when you keep messing with them? They get tired and give out, right? So eventually you're going to go from boggy to firm to tired again. So you only want to respond, you only want to massage till it firms up and then stop. Okay? Don't keep going and going and going.
So
Is
if
there
it's firm, you don't.
If it's firm, if it's firm, she's not bleeding because it's boggy. Okay? So the boggy means atonic. So the uterus needs tone to be able to clamp down to stop the bleeding. So if it's boggy, think like deflated water balloon. Like that. And it's responding to you. It's not atonic anymore. If it's not responding to you, then you need to make it respond. So you keep pushing on it, keep mashing on it, and then what medicine can you give? Pitocin. Yeah. Open her up. So massage it, Pitocin. Now if she's firm and she's still bleeding, what are your other causes? Let's see if you can critically think through that. It's firm. She's still bleeding too much for your comfort. You've changed your pads. You know it's too much. What are some other causes?
Tear.
Yes. Because it's not acne, right? Because her fundus is firm. So it could be that she has a tear. Now what is that blood from a tear going to look like? Fresh from the tap. Yep. So when you're pulling up the covers and you're examining her bottom, if you've delivered this baby, maybe she's got a tear, right? So maybe you're not going to repair that. So if she's got a laceration down there, it could very well be bleeding. So that blood's going to look different than lochia, okay? If she delivered from in another facility and you're transporting her, maybe they missed a tear, or maybe one of her stitches popped. Maybe they've repaired it, but she's had a wound open it, because it's exactly just like a wound. So you're looking for that the edges are approximated and all of that. So critical thinking. Some of these, just because she had a baby doesn't mean other things that you know don't apply. Okay? Bleeding's bleeding. Now, I will tell you, pregnant people, when they lose blood, it's a little bit different. We respond differently to blood loss. So normal pregnancy physiology is that we gain about 40% more blood volume when we're pregnant. Okay? And for those of y'all that have had babies in the room, you can vouch for that, right? There's lots more extra stuff floating around in there. Why do you think that happens? Why do we get all this extra blood volume?
For the baby and prepare for blood loss whenever you're delivered.
Exactly. I could not have said it better myself. To grow a baby and a placenta, and to prepare for delivery. So if we just went right there on his leg and he dropped 500 mLs just like that, what are you going to look like? Pale, all those shocky signs, right? How much blood does a woman lose at delivery, a vaginal delivery? Around 500, a little less maybe. So if he looks like that when he drops 500, but I can go in and have a baby and drop 500 and get up and go to the bathroom and have supper in an hour. How does that equate? It's because I got that extra blood volume. He doesn't. Okay? So that's one of the reasons that we can lose that blood just like that at delivery and be okay. But what would we see in you first? If you were losing blood, you had signs and symptoms of hypovolemia, what would you do? Your heart rate would go, and your blood pressure would go. It's not the same in a pregnant woman. Initially, what they will do, they'll elevate their heart rates, and they will elevate their respiratory rates. If you see a blood pressure change, you waited too late. Okay? We don't drop our pressures first when we lose too much blood. It's just not what we do. Okay? So be thinking about your other, God bless you, your other signs and symptoms of blood loss. She's pale, she's diaphoretic, her mucous membranes and all that sort of stuff are changing. You might actually see some of that in some patients before you see their pressures drop. So don't always go by blood pressure. It's tachypnea and tachycardia are your first two things that you want to look for. Generally speaking, pregnant women's heart rates aren't that elevated. Generally speaking, and they're typically not very tachypnic. They might breathe 22, maybe 24 when they're in pain, but they're not 28 or 30 as a general rule. Okay? What's the number one rule? What's the number two rule?
Keep it warm.
Keep it warm. Okay? How do you actually deliver a baby? And you're going to get to practice this one day. I did not bring the simulator today, as you can see, but I think you're going to get to play with her one day. Anybody played with her, the simulator? You did. In Kernersville, yeah. So how do you deliver a baby?
Head down initially?
You would like for the head to be down, yes. You're probably not going to be delivering a breech baby, or would I? So, yeah, head down. Okay? So, what's the sign and symptom of crowning?
See it.
You see the baby's head. Verify that it's the baby's head. Okay? Don't just say, I see hair, because that might not be hair from baby, right? You need to see more than that. Sometimes we get mixed up. So you want to see, now, you see this much of the baby's head sticking out? That's crowning. Okay? No head sticking out? Probably not crowning. Okay? So that's crowning. Alright? You want to prepare for delivery when you see that. Okay? Now, I didn't bring my baby. I need a baby.
Zoe.
Does Zoe have a baby?
Zoe, do you have a baby?
No.
Do you have a baby doll with you?
No.
Oh. Okay. Here's my baby. Okay. So I can either do my hands like this. All right, let's say I'm at the patient's perineum. Her head's up there. She's there. Okay? So here's my baby's head. See? Now I can put my hands here, or I can put my hands here. Okay? That's fine. Either way's fine. You just want to be careful of the squishy parts. And what are the squishy parts? You don't want to do that. Okay? Be careful of the eyes and the nose and the mouth. Alright? So when you're, hey, there's a baby. That's much better. Awesome. Okay. Let me see, we got eyes. Okay. So the baby might come down like this, like this, like this. Okay? So let's say the baby's like this. Top of the head. Okay? Mouth, face, nose here. Okay? So you can do your hands like this, or your hands like this. Matters not. Okay? You just want to control the head, but your instinct is going to be to what? Push it back in.
Shove it, close your
Right?
legs.
Shove it back in, close the legs, put the covers back on top, alright?
I didn't see that. I didn't see that.
5 minutes.
Yeah. Out of sight, out of mind. If I don't see it, it's not happening.
Put the sheet back over.
Okay. So, you don't want to push it back in though, right? It's coming, it's coming. Why wouldn't you want to push it back in?
That's just not good.
No contraction.
She's not going to like it, you're right. So think about it this way. So that mama's pushing. For those of us that have ever seen a baby be born, it is involuntary, right? Once that baby hits that certain part of your anatomy, it's like, here we come, okay? So she's not going to be able to stop. So that's a power, right? It's a maternal power. We call that a secondary power. The primary power is her uterus, or the contractions that her uterus is having. So there's your primary power or your secondary power. Those powers are not going to stop, even though you're trying to push the baby back in. So you've got power coming from this way, and you put your hand and you're pushing against the baby this way. Is that good? Because what's caught in the middle between this power and your power? The baby. Okay? And what are these little squishy parts? They're fontanelles, right? What's directly underneath those little fontanelles? The brain. And what happens if you push on the brain? It's no bueno, right? Just say. So you don't want to do that. That's going to be your instinct. Very first baby I ever delivered with my own 2 hands. I'm like, woo! Okay, it comes out. All right? So this way or this way matters not. Now, if you look at anatomy, the pelvis kind of does this, right? Kind of has that kind of curve. That's that curve that you want the baby to follow. Because if you do this, what, exactly. What have you just done?
Pull the uterus out.
Well, you've created a pathway. You pretty much just bulldozed the pathway right through. What did you bulldoze? Her perineum, right? So you want to try to protect that as much as you can. A way to do that is you want the baby to follow that curve. So that curve is down, gentle traction downward, okay? And you're going to go down until you see that anterior shoulder. That anterior shoulder is the shoulder that's up, okay? So once you see about this much of the baby's shoulder, the shoulder that's up, so you're going down, here's that shoulder, you go straight up to the ceiling. Literally straight up to the ceiling. And you just followed that curve. See how that's different than that, okay? So down, anterior shoulder, straight up. Generally, if you see this shoulder, the rest of the baby will follow. Okay? Questions so far? We just covered a lot in 35 minutes. We delivered a baby and recovered her.
But you don't want it to deliver too fast, right?
I would say that you want to try to control it as much as possible, yes. Now, sometimes you're not going to be able to do that. You just make sure it doesn't hit the floor. It depends on the patient and how controlled she is. And the size of the baby and how many babies she's had and some of those other variables. But you want to try to control it as much as you can. Yeah.
I may have missed this, but as far as clots, like when do you get worried? Like how many clots, how large, like too large of a clot?
So, I would say first you need to be able to identify the size of the clots. How you do that's completely up to your preference. Now, I was taught to use, you could use fruit, like you could use like grape-like clusters, you could use orange size, grapefruit size, lemon size, lime size clot. We all kind of get a visual picture of how big those things are. You could use money, depending on the size of it, 50-cent piece, quarter, you know, those sorts of things. Fruit generally works better when the things are bigger. I would say because the clots have volume in them as well. I mean, you could have, let's say you had a 100-centimeter clot every single time you checked her belly. Well, then that's 400 ml she's lost in an hour on top of the regular blood. So I would say little tiny clots might not be a big deal if the patient that you have in front of you is telling you that she's okay. You should be getting something out when you check her belly. It should not be like nothing, because you're probably not checking it hard enough. Because she's telling you it hurts, so what are you going to do? You know, that's not a bundle check. She needs to at least go, okay? And I bet if you think maybe she's bleeding and you do it extra little hard, maybe because you haven't been doing it firmly enough, you're going to get a great big clot out behind it. And then you'll see the
Great big meaning?
Could be this size. Could
So
be
you
half
wouldn't
this
worry
size.
if you saw something that big?
I'm going to look at my patient. If I've just expelled something this big, I'm going to say that's a, what is that, grapefruit?
Yeah.
Grapefruit size clot expelled with bundle check. Fundus remains firm. Pitocin increased to 125 mLs an hour, or whatever it is that she's running. Maybe I would go up a little bit. I would check a vital sign. I would check a heart rate, and I would look at your patient. Because I might be able to tolerate this just fine. I might not be. I'd like to give you a number. What I would like to see is that your documentation supports that you knew that you needed to be concerned about a clot this big, versus just checking her every 15 minutes and being fine with it.
Will the Pitocin increase her heart rate also? Does that have that kind of effect?
Pitocin drug itself doesn't, but I think if you ran it in quickly enough, it's going to do what any other fluid bolus is going to do, and make her blood pressure, you know, make her circulate it. So,
Your
not
pain's
because of
gonna-
the pit.
Your pain's gonna be higher, right?
Your what?
Your pain with Pitocin?
She might, yeah. It's probably going to make her might make her afterbirth pains stronger. But I will tell you, the other perfect thing that you could do, if you've had a delivery, let's say your baby's 38 weeks, how are you going to control her bleeding? There you go. There you just fixed your problem. That on top of the Pitocin, her uterus is going to start to really clamp down. Then she's really probably going to complain of afterbirth pains.
Can you infuse Pitocin too fast if she's bleeding? Like, is there like a limit where you just don't go?
One of the side effects of Pitocin is water intoxication. I've never seen it in my practice, but I mean it is. If you were to read about Pitocin, it is a complication from it. I would say you have to manage the patient in front of you. It's a drug. You wouldn't want to give anybody else a drug if they didn't need it.
Right.
So if you think her bleeding is under control, you don't necessarily need to turn it up.
Is there like a certain like how? So when you hang like dopamine or Levophed, you know, you go by so many mics every so often. Is there something like that with the Pitocin?
We generally bolus it immediately after delivery. Like if it's on a pump, we'll turn it up to like $9.99 or whatever. And then we'll titrate it down based on what our bleeding is like.
Okay.
Yeah.
During that bolus.
Yeah.
Okay.
Yeah. So she delivers, the baby on the breast, up the pit goes. But, you know, if the placenta's if not delivered, then do you want to do that?
No.
Why not?
Want to expel
Placenta's
placenta?
still in there, right? This is my placenta. I put pit in her uterus.
This is like a cork.
Ooh, on top
There you
of
go.
the placenta.
Right. So you want to use that critical thinking. Generally speaking, she's probably not going to bleed a whole lot if the placenta's still in. She might. She might not.
So you wouldn't really want to start the Pitocin until after the placenta was facility?
Not necessarily. I'm not going to tell you exactly because there's always an exception to every rule. I would manage the patient in front of me, but she's probably not going to have a whole lot of bleeding.
Okay, we've delivered this baby.
Yep.
And up to the ceiling.
Up to the
We're
ceiling.
gonna put it on mama's chest. What else we do? Just rub it down vigorously, make sure it's got airway, and
Yep.
that's pretty much it?
Yep. Vigorous. Not. You're the baby, you're so cute. No. It's, I take the back and I go up and down the spine. Yep, up and down the spine. You know, and the neonatal resuscitation says you could do the soles of the feet. You know, we used to joke and say we turn babies upside down and slap them on the fannies. Don't do that. But vigorous rubbing, call that tactile stimulation. If you've got those warm blankets and towels and everything, and you're wiping off that baby and wiping off the baby's head and everything, you're gonna stimulate it. But they're more resilient than we give them credit for. So you could be, I mean, you could really be vigorous with these babies. You want them to be pinking up and you want them to be crying. And people are like, oh, don't cry. No, I want you to cry. Why do I want you to cry? Clear the airway. Because what have I been doing for 9 months? Breathing water. And now I got to go from water to air. So what do I need to do to get that water out of my alveoli? Cry. Right. So you want those babies to cry.
So whenever they're delivered, that water that's inside their lungs basically gets squished out. So
Yes.
we don't have to worry a whole lot about it.
Are we
The suction
suctioning
part.
the mouth and then
Yep. So when babies are down in the perineum for a while, they get a good squeeze because they're kind of hanging. And they go a little bit forward, a little bit back, a little bit forward, a little bit back, till they're all out, right? So when they come down in the pelvis quickly, they don't get that kind of as good of a squeeze, prolonged squeeze, if that makes sense. So they might have more junk and gunk in their lungs because they didn't get that kind of good squeeze. So you might see that in babies who've delivered precipitously. You don't have to have a bulb syringe. I think you have one in your kit. So hold the sides together. And where do you put it? In the mouth. Are you sure?
Nose, mouth.
You were right. Think M before N in the alphabet. Mouth before nose. That's how I remember that. M comes before N in the alphabet. Because if you put something in my nose, what am I going to do? Flinch. And then as a baby, all that gunk I got right here in my airway, I just went and flinch. Where's it going to go? And I'm going to suck it right down. So if you get it all out of my mouth and my airway, when you get to my nose, there's not much in there for me to suck on. Does that make sense?
We can use wall suction too, right?
You don't even need to. You know what'll suffice? This, scooping it out. Yeah, I wouldn't go any more invasive than you need to. If you, in a pinch, there was a lady out there in the parking lot, we didn't have a bulb syringe, and I delivered that baby. I would take a towel until I got one and scoop out that baby's mouth and get all that gunk out of the mouth. And then if somebody brought me a bulb syringe, I would use it. So you don't have to have it.
Okay.
We'd still use them, but you know, I wouldn't go invasive unless you needed to. I would go towel mouth or bulb syringe. That's generally going to get your job done. Okay. So we delivered it. You got your Apgars. We suctioned it. Got it all warm. It's screaming, crying. We put it to the breast. We clamped, cut right in the middle. Baby's breastfeeding. Mom says she feels crampy. That's good. Could you give her pain medicine? I don't know. Y'all tell me.
She can wait.
Exactly.
Does not
block the boat. You got this.
Okay. She might complain of some discomfort, but she might not. So that's completely up to y'all whether you give her pain medicine or not. Some patients get some morphine after delivery. Some patients don't. Some patients just get ibuprofen and Norco and they're fine. But let's go back a couple of steps. I talked about postpartum checks, those fundal checks. And I said that her uterus was tonic. So that means it's firm, right? But she's still bleeding. We pulled up the covers. We don't see anything that looks like it's coming fresh out of the tap, right? And sometimes you have to pay attention and stare at the area. Let's just be honest, because you might see a little trickle. That trickle could be coming from a tear. It could be a perineal laceration. It could be labial. It could be on up back in there that you don't see. Let's say you don't see anything. No blood fresh from the tap. Okay, but she's still bleeding. What's the first thing I want you to check? You know? Besides her fondness, because we said it was tonic.
Blood pressure, heart rate?
Her bladder.
Her bladder.
What if her bladder's full? Check her bladder. Okay? Because what happens, so the bladder's here, and the fundus is here, right? So eventually I'm going to start competing for space. Okay? So if I don't have enough space to squeeze as a uterus, I might start to lose my tone and I might bleed, right? So you want the bladder to be out of the way. So you might have to catheter. Okay? She's not going to like that very much. She doesn't have any anesthesia.
So you'll have to catheter?
You might if she can't pee. Yeah. Now, if she can go, she might not need to. She may have gone while she pushed. It's just one of those things I want you to think about. If she's still bleeding, and maybe you don't think it's coming from her because her uterus is not toned, then I want you to check her bladder. It's just one of those things that's important. Might not matter.
A full bladder will slow down labor, right?
It could. Yep.
Now, how did you? I apologize. I think I might have missed it.
No,
you
you're
might have said it. How do you check the bladder? Did you say there's a specific way of checking?
No,
it?
you just if a bladder is full enough, and it's generally not going to happen with somebody who does not have anesthesia, because she's going to tell you I have to pee. Okay. But you just think she's had some trauma to the area and things probably don't feel right, so she might not have that good sensation. So maybe you want to ask her, do you feel like you need to go to the bathroom? Offer her the bedpan, or you might be able to actually palpate the bladder, depending on how full it is. Hormones make the bladder extra stretchy, so we're able to hold more when we're pregnant than when we're not pregnant, just because it makes the bladder, that smooth muscle stretch. Okay? Other questions? We've done a whole lot.
So we're delivering, and
Yep.
it starts coming out the cord wrapped around.
Okay, good question. What do you think you do?
Push it back in.
Don't push
Drive
back.
faster.
Tell her not to finish.
What you want to control her? That's exactly right, because you need to buy you some time. You need to buy you some time so that you can check to see if you can what we call reduce that cord, which means take that umbilical cord. Let's say it's wrapped around the neck. Okay, take that umbilical cord to see if we can lift it over the head. Generally, they're pretty long, and there's some space to do that. Okay, so you want to reduce that cord. Okay, and then the baby should come out. Some babies deliver through them, and it's no worries. Some babies you need to reduce it. Okay, so you need to try to get it
What
out.
happens if the cord's out before you even see the baby?
Well, that means you're asking very great questions.
See, this is what
We're going to see. We're not going to see a head pop out and also like, oh my gosh, it's a miracle.
We're going to see feet. We're going to see.
So
I'm going to see a toe.
feet I can't help you with, because I don't deliver feet first babies. So that could mean that you need to divert to someplace else. That's closer. Okay, that's
Nine
a
times
call.
out of 10, there's not going to be
Okay,
anywhere.
so then you get to where you need to
Just
go.
go past.
Yeah.
Just tell her not to push.
Yeah,
Or
yeah. Try to control her, coach her through that. Try not to push. So if there's a cord hanging out, and this is where some people get confused. So you can, and you should, take your fingers, put them up in the patient. It'll be very uncomfortable for some of you in the room. And you want to push whatever that presenting part is off that cord. Because that cord's hanging out of the vagina, and whatever's following could do what to that cord? Squish it. And what is it? Why is that cord important? To who?
Baby.
Yeah, I call it the super target. It's the grocery store. It's got heaters and refrigerators. It is everything for that baby. That plus uteroplacental cord unit is the super target. And you know, we get used to going to the super target for the groceries, and they take the groceries away one day and we get mad. Okay? Babies are the same way. So they don't like it when you're messing with that whole system. So you don't want what's coming out to squish on that cord. So you're not doing a vaginal exam, which is what some people, that's not a vaginal exam. You're not examining her cervix. You're not telling me how dilated she is. If you can stick your hands in somebody's chest and massage their heart, you can stick your hands in their vagina. Just saying. Just saying.
So you're saying move the part, not the back end?
I'm saying if this were the baby's head, I need a cord.
There's a rope in your
You got a rope?
Oh, I've got a rope.
And
Weirdly.
here.
Where do you
There
have
you
a
go.
rope?
There's
There,
one.
we
I got
got
one. Okay. So here's our head. This is good education. And here's our cord, right? It's not supposed to. It's supposed to come out like way back here, right? So if it's coming out before, what you need to do, and it's not generally that long.
So what's protruding out of the vagina that we're looking at?
This is the umbilical cord. Okay. The rest of that stuff can't see.
No head.
Okay. So here's the head,
Benji.
right?
Uh-huh.
Here's the cord hanging out. Okay? So if you think about it this way, this head is going to smush this cord. That's not what you want. Okay? You're messing with the super target. So what you would do is take your hands and you want to push this head, could be feet, could be bottom, whatever's presenting, that means whatever's coming first, and push that off the cord. Okay? Generally it's going to be kind of like that, just enough to get it off. Okay? And guess what?
And just stay like that till you get to wherever you're going.
You just hold it.
Hold there.
Now,
Just like that.
So you don't try to push to it and bring it on out, or you just hold
You
it.
would not do that.
You just hold the head up until you get
Hold
where
that
you're going.
presenting part off. Yeah. Now a good
Are you
what I
driving fast?
I'm going so slow. Hurry up.
I did that before.
Yeah. So that is not a vaginal exam. You can do that. Okay. Some people were really I can do that. Yeah. You're not examining her cervix. That's a credentialed skill that you would have to be oriented on, and you're not doing that. Okay. But the whole point is to get whatever's presenting off of that cord. Okay. Because you want that baby to keep that blood supply, those nutrients and everything. You don't want this to be squished.
There will always be something presenting that comes out.
Not necessarily. Well, no, not necessarily. Let's say the baby's breech and she's very early, 28 weeks or something. That baby's very small. Then the cord could come out, but there not necessarily be anything immediately following it. So how would you tell me that your baby's okay? Or how would you examine or assess your baby?
Fetal heart tones?
There you go.
Oh,
Drop
baby.
baby.
Rope rule number 1.
I did. Okay, so your fetal heart tones. Yeah. Is just a good way to know that the cord might be hanging out, but if it's not being pushed on by anything coming out, then it might be okay. Okay? Maybe, maybe not. But you at least know what to do. If you see this, she says, I feel something hanging out. And you look, and there is. And, you get that fetal heart tones, and let's say they're 140. Okay. I might be okay with that. Or they're 70. I'm probably not okay with that. Okay? Does that make sense?
Yeah.
Okay. Love the chord. Improvisation. Okay? So we've had a whole baby. In less than an hour, we've gone through a whole lot. We got 20 minutes. What do you need clarified? Or what questions do you have?
Preterm delivery.
Essentially the same. What will be different, of course, is what your baby, depending on your gestation, what your baby looks like. The delivery is the delivery. It's exactly the same process. Depending on the gestation of the baby, it may come out faster because it's smaller.
They can get head bleeds from that, right? From coming
If
out
they're
too
born
fast?
early,
Preterm? No?
I guess technically they could. Yeah, I guess they could. But if they're coming out, they're coming out. You're not gonna hold them in. But you could be doing some medication interventions to keep them in. What would those be?
Magnesium.
Mag.
Terbutalin.
Say it again.
Terbutalin.
Terbutaline. Yep. Okay. So here's this patient. She was at X hospital for preterm labor. Okay.
Just like
So she's there. and she got some fluid boluses, and they're trying to prevent her labor, and it's not going to happen. And they call y'all, and you come, okay? So then you use whatever protocols you have. She's got MAG, and let's say they gave a dose of terbutaline. She got a bunch of fluid bolus